Good evening, everybody, and welcome to the SightCare member webinar. We're delighted to be providing this webinar this evening in partnership with the Body Doctor. The Body Doctor are an organisation who work very close with SightCare, support SightCare and support independent practice. So we're really delighted to be working with them this evening. This evening's webinar is, as you know, about healthy lids, managing blepharitis. And we're privileged to have Mussa with us this evening. Roz is a very experienced CLO, and she's the Learning and Development Manager for the Body Doctor. She's also an author, a presenter, and she's over 30 years experience. So we couldn't ask for more in terms of having an expert this evening to talk to us about this very important aspect of optometry and eye care, blepharitis. So without further ado, I'm going to hand you over to Barry from the Body Doctor just to give a little bit of housekeeping, and I hope you enjoy this evening's webinar. Thank you.
Thank you, John. Good evening, everyone. As John noted, just like to go through a little bit of housekeeping, just give you an indication of what we do this evening. So the webinar content will be recorded, and as attendees, you will be muted and can only be unmuted by one of the panelists. At the end, we'll be holding a Q&A, so please type your questions into the chat function. Once the webinar has finished, there will be a short survey, so please answer the questions honestly so we can continue to improve these sessions. Following this, you'll receive a thank you email with a link to download your CPD certificate, so please keep an eye out for this email as well. So that's my housekeeping all in order. So Roz, over to you.
Hi, good evening, and thank you everybody for joining me this evening. So I wanted to just quickly, before we start the CPD, I know there have been quite a few questions about how to set up dry clinics, etc. That's not really part of this CPD, but we can have a look at that at the end of this CPD if you wish. So I've got a lot of experience. I work in practice. I spent over 12 years setting up and running dry clinics. And I also work in education quite heavily, as John and Barry have both said. So let's crack on. I am the Learning and Development Manager for the Body Doctor. I also work in practice. And I just want to say thank you to our sponsors this evening for sponsoring this webinar, the Body Doctor, and thank you for SightCare for hosting it too. So here we go. It is a lecture, so it's one CPD point. You've got the C number and the QR code there, but please don't worry because you're going to get an email at the end, which will also have this on there, so you don't have to worry about taking it down at all right now. So I wanted to start by setting our expectations. What are we going to cover? So you've got a bit of an idea of the agenda of the evening. So dry disease. Why is a healthy ocular surface important? The relationship between dry disease and blepharitis, and the management options that we have in practice and at home. Okay, let's start here with our webinar, a refresher. If you Google the eye, it's actually a relatively simple structure, but it has really complex functionality. And if we think about our role, and even in my lifetime of working in optometry, which is 30 plus years now, it was really about refraction. It was about refraction that gave us an idea about the functionality of how well the eye was working. Obviously now we have scanning equipment, so that makes life a lot easier with our OCTs and our optomats. But before that, refraction was really our key skill. And we are brilliant refractionists, but let's remember this, the anterior eye is responsible for 60% of your refractive error. It's the only part of the globe that's exposed to the environment and all the influences that brings to bear. So that's, you know, the air conditioning, the heating, the hot, the cold, the computers, the handheld devices, walking in the garden, the pollen, etc. And it's bathed in a highly organized and very sophisticated structure, the tear film. And what we're really investigating this evening is a malfunction in that tear film. So let's have a look at the structure of the tear film in a little bit more detail. I know we've always talked about it being 3 layers, but for accuracy's sake, let's be honest and say it's 2. So it is actually 2 layers. It has a pH level of roughly about 7, which goes a long way to supporting a happy and healthy ocular environment. And it is a dynamic structure. So let's have a look at these layers. Now, the lipid layer is produced by those all-important meibomian glands, producing the polar and non-polar lipids. The mucus layer is produced by your goblet cells on your bulba and palpebral conjunctiva over the cornea, and the aqueous layer is produced by the lacrimal gland that filters the blood plasma and pumps its aqueous onto the front surface and mixes with the mucus, and it's the glycoproteins within the aqueous that give it the pH value. And then you've got this amazing layer called the glycocalyx that coats the epithelium. It's a carbon-rich structure, and it goes a long way to stabilizing the tear film, as well as making sure the bacteria can't really colonize against the cornea, so it protects it in quite a big way. And it's often a break in that in that glycocalyx that starts some problems with the tear film structure. So with that in mind, let's think about that malfunction and think about the report that was commissioned by TFOS. They commissioned a report, DEWS, which gave standardization, management and classification to dry disease, as well as giving it international recognition. So this really standardized our approach, and a lot of the studies since have become a lot more unified in their thought process because they use DEWS 2 as their kind of bedrock. And if we look at the evolution and understanding between the two definitions of 2007 and 2017, and we know there's another report coming out possibly next year. If we start at 2007, it talks about dry disease being a multifactorial disease. So it's a disease, and what does that mean? A malfunction. It's so something that isn't a disease will be a broken arm. It would fix, but a disease is a malfunction that you can't fix. It's a chronic condition. It is multifactorial, and it really concentrated on the fact that we were looking for patients that had symptoms of discomfort and visual disturbance, and they were actually coming in and reporting this. Move across to 2017, and we're starting to get an understanding of the mechanisms that are in play. So it's still a multifactorial disease of the ocular surface. So it still characterizes that malfunction as something that's chronic that we can't fix. But it's characterized by a loss of homeostasis. And what is homeostasis? An example of that would be one's ability to maintain body temperature irrespective of surroundings. And we do things to aid that, don't we? We kind of like put on coats, or today I'm wearing like a short sleeve shirt and a loose clothing because it's so warm. The key really is, that's triggered by hyperosmolarity, and you have tear film instability, and there's surface inflammation, and the nerves get involved as disease and starts to take hold. So that's really our understanding of what's going on. And if we go to, the next layer, the next area, we're looking at the diagnostic pathway that DEWS 2 have provided us as well. So before management comes diagnosis. Now, this diagnostic pathway that you see here isn't just applicable to us. It's applicable to all people in the medical field, right? In the medical field. So that means your doctors, your nurses, your dentists, your pharmacists, and us. And if you look at it a lot more closely, we're quite lucky because actually it's our contact lens assessment, if you like. It's our triaging questions out of which you pull risk factors. I think the only thing they've really added is in your diagnostic text, there is a potential questionnaire that you could ask. And they've given you two very gold standard questionnaires, the DEQ5 and the OSDI questionnaire. And then you've got your homeostasis markers, and really what they're saying here is they're asking you to go more towards your non-invasive before you go towards your invasive homeostasis markers. And we pretty much know that because we know that fluorescein destabilizes the tear film, we know that pressing the glands, etc. Sorry, there's a message that's come up that's distracted me there. So we know the tear film destabilizes the fluorescein destabilizes the tear film, and if you press the meibomian glands, that pollutes the tear film. So try and investigate non-invasively first, and then you will come to what is actually triggering your disease. I mean, evaporative is generally where it starts. It's the most common form. But invariably, because this is a dynamic condition, as in if you have one area that fails, that will eat into the other layers, that's what we're asking you to consider. And fundamentally, you're going to get a mixed level of dry eye disease. The other issue is that somebody could well have evaporative, and then as they age and they start to become, you know, they have different diseases that start to develop as we age, then they will probably have some aqueous influences too. So that will push the disease progression a bit further. So even though it kind of pushes down a pathway, do remember that they two will be combined. So concentrating on this evaporative pathway, the tear film, TFOS and DEWS established this, and I don't think if we read this anybody would be surprised that the prevalence of dry disease based primarily on science is higher, with the estimates being about 75%. So really we see it before they complain about it. But is that really the case? That's what I want to ask, because how often do we see this when we look down a slit lamp and you ask your patient how are they feeling, and they're kind of like, no, everything's absolutely fine. But is it really, and they just kind of ignoring those low level symptoms and they just learn to live with them? Because how many things do we all learn to generally live with until it becomes a real impingement on the way in which we function? So we're really talking about stepping in at this stage before it becomes to be really debilitating. And so we're really concentrating today on blepharitis and healthy lids. So here we've listed the two different types of blepharitis that you generally tend to see that leads to lid irritation, and then chronic eye, like red eye, and then you're going to get dry eye. So what we could definitely say, blepharitis is the most common anterior eye condition and is a precursor to evaporative dry eye. And we're going to have a look. Let's just break down the different types of blepharitis. So you've got staph, where you've got bacteria involved. We don't really understand why entirely. We kind of think it's because the tear film isn't functioning as well. Therefore, it allows the staph to grow, and the biofilm builds up on the lid margins. You've then got the seborrheic, which is where you have the sebaceous glands involved, and those are the glands that help keep those eyelashes quite moist and lubricated. So you start to see those eyelashes flaky and dried oil and oily lid margins, etc. And then you've got the good old demodex. You've got two types of demodex that live on human beings, on human beings, us, the follicularum, and the brevis as well. Now, every single person on this call does have demodex, by the way. It's just when their numbers get to a point which they're too high that we start getting problems, and we start seeing things like cholerax, and it's also the bacteria that the demodex start to carry. And the more demodex there is, the more bacteria they carry, and therefore the more bacteria you get in the area, and then the itching starts. And because of where they live, you get the lash misalignment as well. And you've got posterior blepharitis as well, which is meibomian gland dysfunction. You will have some demodex involved in that, but you don't really see it as well. So you've got an unstable tear film as a result, quick tear breakup time. As we know, it's a quality and quantity thing, so the secretions thicken. You get foaminess in the lower lids due to the bacteria, and the glands start to block. So really, let's have a look at the relationship between blepharitis and dry eye. Well, we know the two are clearly linked, but as we said before, it is definitely a quality and quantity issue of how much meibomian is being produced. So you could have great quality, but because you're staring at the screen, you're not blinking enough, right? And you get some inflammation in the eyelids, and when you have that inflammation, you then get, doesn't matter how good the quality is, there's going to be a reduced output from the meibomian glands, which then means there's an ineffective lipid layer, and then you get a precursor to dry eye, and then that just starts the whole cycle to begin, and homeostasis starts to break down, and that inflammatory disease cycle begins, and ocular surface damage starts. So you can see very easily that if we could actually step in here, and often liken it a bit to gingivitis and that kind of thought process of brushing the teeth and flossing. So it won't be that, you know, if you can kind of step in at that point, you really will make life a lot easier. But what are the management options? Well, we know, regardless of anything else, and the College of Optometrists management guidelines, and you have a plethora of things to manage with, But lid hygiene is the first line of management regardless of the types of blepharitis, because there's lid complications that occur with tear film instability, different types of blephars that we've talked about, chalazion, gland dropout crisis, telangiectasia, which is a word that I can never say. So we really do need to start getting in. But, you know, where do you start? How do you start? What do you do? What do you pick? Do your patients really want to comply? All of that kind of thing. So we've already touched on this, and I've just touched on it. Compliance is very poor, right? Now, why is that? So if we look at the psychology behind this, I've just brought up this health belief model. Now, actually, this health belief model isn't just about health, it's about every action that you take in day-to-day society. So here you have on your left-hand side, as you're looking at the screen, the demographic variables. So this is your person, right? This is your class, gender, age. So who are they? So let's put me into that. I am female, I'm in my 50s, my personality type is I'm reasonably compliant, my peer group is going to have a pressure, I have some great fun friends, so that always kind of makes me sometimes push the boundaries a bit, etc. So I will give you an example of this, because I used to work at Johnson & Johnson Vision Care Institute, and we used to have to deliver courses very early. We had to be there by 7:30, 8 o'clock before the courses started for the delegates to come in at 10. So we always used to have to go up the night before, sleep over, so that we could get to the institute, which is out in Reading, you know, if you weren't living too close. And I had, in my 40s, the most gorgeous Audi TT. She was racing green, and I used to polish her like crazy. And she had a really white leather, beautiful white leather Napa seats. But living in London, and I live in North London, there really wasn't much of a chance to race this car. I mean, I was driving around like Miss Marple. So I used to take my opportunity to drive to Reading as my opportunity to race the car. And for that reason, I would leave late at night. Okay, so my motivation, so if we go to this diagram, the middle line is health motivation, actually action motivation, I would say, was to race this car. My perceived benefits is that I could actually feel her move, and it would be fantastic, right? It would be amazing. What were my barriers? Well, I didn't really want to hurt anybody, right? I didn't want to have an accident if I raced this car and hurt anybody. So I went to my perceived susceptibility. Well, what was that? If I race late at night, there's going to be less cars on the road, and therefore, if I do have a crash, it's more likely that I'm only going to hurt me. I'm not going to hurt other people. So my motivation to race late at night on the roads was great, and I knew where the speed cameras were, so I knew where I could really push this car. So that was me. I was gone, right? I was in, and my mode to action, the thing that stopped me is that they changed where the speed cameras are, and I got caught, and I just managed to slam on the brakes, and I did skid the car. It was quite crazy. But I just managed to get in, bring the car down in enough at enough pace to get one of those not points or banned, but actually get to the point where I had one of those, had to go online and do a special course, etc. So that was my cue to action. So once I went on that course, and it made me reflect upon my actions and what I could be doing, actually knocked this health belief model completely out of kilter. And I sold my beautiful TT, and I now have a very lovely car, but I do drive like Miss Marple, even on the M4 and on the M25 and absolutely everywhere. So I guess what I'm saying is you are the cue to action, and if you can't change the way in which somebody is, if you're getting the same results every time, think about what you're saying, because character and personality is acquired. You can watch people and change. So if you're not getting what you need from the patient over and over and again, and they're not listening to you, maybe change the way in which you're saying it, because you are the cue to action in order to make a change to this health belief model. And there are a couple of things that you can do to help that. The first thing is this: make it relevant to that person. So take an image of their lashes. So even if they don't have symptoms as such, you can take an image and show them what the front surface of the eye looks like, and how that and how that doesn't look very nice, and what you can do to actually help it. And there's lots of different things you can have in practice to help do that. It doesn't have to be an expensive piece of kit. There's some great piece of kit called AOS software that can take all these amazing images for you and do the grading for you. You can have a camera phone that's attached to your slit lamp. You can have your topographer that's got part of it, or you can have a really sophisticated slit lamp imaging system, whichever you want. But if you can talk about their images, that will definitely make it more relevant to them, and you'll find that compliance does improve. Now, I'm always asked, out of all of the things that are on my shelf, which do I think is the easiest for the patient to use? Now, there's lots of things out there, but I've got to say, I personally love hypochlorous acid. Now, what is hypochlorous acid? It is a very weak acid that is produced by our white blood cells in our body. And I've kind of shown it there. It destabilizes very easily in a synthetic form, so you have to think about that. But basically, the white blood cells comes in, it absorbs the bacteria, and the hypochlorous is thrown all over it, and that destabilizes and denatures the bacteria and effectively kills it. So these are the three that are available in practice. It's a really nice antibacterial and anti-inflammatory and antimicrobial, and it doesn't damage the other fauna and flora of the skin. So it's a real harmonizer, and it's a bit of a no-brainer. And for all those patients that just can't, just can't open packets and heat things up in microwaves that they don't have and all of that kind of stuff, want to lie under bags, actually this is a bit of a no-brainer. It's literally spray and leave, and it doesn't matter where it goes and what it does, and you will find that it brings that inflammation down. And the anti-inflammatory aspect is what you need, and antimicrobial is what you need when you're managing blepharitis. So those are the three that you have just on your shelf. It's really underutilized, and it's really, really good. So please start looking at that, is my one top tip of today. The other thing I think we absolutely need to do is, compliance is hard for all of us, right? We're all busy. I mean, look at us on this call, we've had to eke out the time. So it would be really useful if we could do in-practice treatments to complement the little bit of take home. And then you can reduce the amount of take home and reduce the burden on the patient and do a lot of management yourself. And you can watch how it's going, and you can give them progress reports as well. So here are a few of the obvious practice of treatments that are there for us. So we've got that, we've got the new lids and the Blepharitis, and we've got Zest. So new lids and Blepharitis, very similar instruments. They basically exfoliate the area. Zest does the same thing. You've got IPL, you've got plugs, and you've got LipiFlow. And these, like Zest and new lids and things like that, it's not new. I mean, golf spuds have been used for ages, and they're used more in hospital settings nowadays, but basically they're designed to remove the foreign bodies, and like in the hospital, but actually they used to be used to scrape all the meibum away, that biofilm away from the lid margins. We also obviously had the baby shampoo. Hopefully nobody's still using that, and the bicarbonate of soda. But you can see it's all about exfoliation and really removing that bacterial load, and that's what the baby shampoo was for as well. So, so your in-practice management treatments are the ones that are easy, are your Blepharitis, new lids, and Zest. So your Blepharitis, you're really talking about debridement. Same thing with your new lids, you're really debulking that area. Your Zest also does exactly the same thing. It's a much gentler form than the other two. It's got this little foam that basically foams up like shampoo, and it's like a micellar water technology that just literally cleans the lashes. It's ochre based, which is high in tannins, so it really removes the bacterial bulk, and the polysaccharide really harnesses that cytokine action. So when you have homeostasis breaking down here, the cornea gets a message, and it sends a message to the lacrimal gland. The lacrimal gland releases aqueous that has more cytokines in it, basically saying there's inflammation going on, please help. So effectively, it's like on top of cleaning, like both Blepharitis and new leads do, it actually then on top of that kind of like almost gives a bit of an ibuprofen, a localized anti-inflammatory to the area. So I think if you can deploy these kind of in-practice treatments along with imaging, along with making it about that patient, along with a little bit of in-home compliance, straightforward stuff like wipes or hypochlorous or heat bags or whatever you think is easy, then I think you probably find compliance gets a lot better, especially with those patients that we think have signs before symptoms, because we want to get to them before they have the symptoms. So as I said, this is what we're going to get when we kind of like debride with Blepharitis and new lids and zest. This is what you have before, this is what you have afterwards. You've debulked the biofilm, you've removed the biofilm, you've debulked the bacteria, you've opened up those glands, you've removed the source of inflammation, and therefore the inflammation around the glands relaxes and clears the way for actually the patient to actually treat themselves a lot better. So that's really what we're hoping to do. I hope you've understood that that's what we're trying to achieve here. So what do we know? We know that Blepharitis needs managing. It is a precursor to dry eye disease. And what we're trying to do is we're really trying to flatten that curve. And the only way of doing that is really through explanation, through imaging, through some in-house work, and really communicating why that home treatment needs to happen as well, but make it as take some of the burden away, start doing some stuff yourself in practice, and your practice will grow for it and they'll thank you for it. So I really hope you've I've tried to get through that and get the points across to you as well as possible. I hope that made sense and you kind of followed what I was trying to say. I just want to say thank you for your time and thank you for listening to me. So I'm going to open it up now to some questions. So John, Barry, if you'd like to appear like genies, that would be fabulous. Thank you very much.
Okay, so what I'll do, Ros, is I'll just to let everyone know that I'll unmute them and they can ask questions. John, I'll hand it over to you just while I unmute all the attendees.
Lovely. Thank you, Barry. Well, first of all, before we go into the questions, thank you so much, Ros, for that very, very interesting webinar. I, as a non-clinician, found it very, very understandable. So that is obviously a very good indicator of how well one is presenting. So thank you very much for that. Right. Okay. So as Ros said, she's here and ready to take your questions. So please take advantage of Ros's experience. And Barry, are we just about there ready to allow people?
Yeah, so I have requested that they accept the unmute request. Doesn't look like, oh no, we do have a couple coming through. So Maria, I don't know if you have a question.
Just in general, we use the IPL. How, once you've done a series of treatment, do you have to repeat that like yearly or 6 monthly, or how does it work?
Generally, I mean, this is an inflammatory condition, right? So you absolutely will need to repeat it. And I think it depends upon the severity, to be honest with you. So were you doing it for rosacea as well as lids? How bad was it? What was the situation, Maria?
Yeah, well, it's different. We do it on different patients, but yeah, it's mainly for lid control. Yeah.
So it kind of depends. I mean, it really does depend upon how bad it is. So, I mean, for some patients, yes, in 6 months. What I tend to do is do the treatment and then see them in 6 months and see where their symptoms are, if that makes sense, and see if it needs to be redone then, or whether you can kind of like leave it for another 6 months. And I often find that's really useful. So whether you're doing IPL, whether you're doing zest, whether you're doing, I mean, zest usually works with IPL quite well, as you probably know. But so whatever you're doing, I always tend to get them back in for a follow-up anyway, to kind of say, if you think about it a bit like a contact lens process, you know, you'd kind of like fit their contact lens and you get them in for a checkup to make sure everything's working and fine. Does that make sense?
Okay.
So I do exactly the same thing for IPL as well. Sort of like, you know, get the treatments done and then see them in 6 months. And then that way you get an understanding of how well that treatment is working for them. And also, you know, a year's quite a long time. Things can change in people's lives quite a lot. So it's good to get them back in and kind of like understand the history, symptoms, whatever's happening. And it's really nice to say to them, actually, you know, you're doing really well. I'm really liking how this treatment's worked. I'll see you in 6 months. No need to do any more. It's great.
Okay. No, that's good. Thank you.
No worries.
So there doesn't seem to be that many unmuted. Oh no, we do have another one.
Are there any in the chat, Barry?
None at the moment.
Oh, hi.
Hello.
Yeah, I just wanted to ask, have you got any patients who have reacted, you know, adversely to the product? So maybe like Zest, because some patients are really quite sensitive, and I just wonder if, yeah, if we apply these, if we're going to get any adverse reactions that are quite common.
I have to say, I mean, all of the everything that you kind of give, there's a potential side effect. I think when you're looking at from all the papers that I've looked at and in my own experience, and all other clinicians that I kind of like tend to talk to, the Zoccola system seems to have the least reactions. So so that's your Zest system and your Zoccola shields and those kind of thing. So they you know, there's not a huge amount of research out there on it, but what I can see, that seems to be the case. And then anecdotally, from what I'm hearing as well, and from what I'm using as well in practice, that's what I tend to see. What kind of reactions are you seeing? What are you worried about?
So we're looking at starting this up. So we haven't started using the Zest, but that's the one we're kind of interested in. But then we don't want a situation where a patient comes in wanting you to help them, and then they probably leave with puffy eyes, red eyes, or just some sort of breakout. So yeah,
there's very little to react to in that. I mean, it's you know, it kind of cleans everything. It's not even that like, I really like Blepharitis and new lids for debriding, but you know, it's aggressive, right? Because you've got this little piece of equipment going. So where the Zest is really winning out on that, because it's completely cleaning the air in exactly the same way and debriding in exactly the same way. But what I'm also seeing is, because it's reducing the inflammation, the tightening of the orifices, you know, those meibomian glands tends to relax and everything comes out a lot easier. And the patient just tends to feel a lot more comfortable, and it doesn't feel as awkward to them, and they feel a lot more comfortable having that done than, say, Blepharitis or new lids. So do look at that. And if you're going into IPL, that's a bit of a no-brainer, because it really makes the eye feel so much more comfortable before you have IPL, and it really aids that first IPL kind of like, you know, all the meibum coming out of the glands, because it's reduced that inflammation as well. So it's a really good one. I haven't so far have anybody react to Zest as an in-house treatment.
Okay.
So far.
Thank you.
That's all right.
Where
is your practice, by the way? Where are you? Where are you based?
We're in Kent, Dartford in Kent.
Great. Well, good luck. Let us know how you go.
Thank you.
Sorry, Rosa, so we've got Anne who's unmuted. I don't know if you have a question, Anne.
No.
Okay. If you haven't accepted the unmute, or there was a problem with you accepting the unmute, if you do have any questions, you can type it in.
Can I, while people are doing that, Barry, can I perhaps ask, of the attendees tonight, would you mind putting your hand up if you're actually running an enhanced service for dry eye? So this is where your patients are actually coming to your practice purely to attend that clinic, and you know, and where you're using that as an income stream to your business. I'd be very interested to know what sort of penetration of specific dry eye clinics are in operation. Mohammed put his hand up, as I was aware. Mohammed had one, so that's good to know. Is nobody else who's attending this evening running what I call a bespoke dry eye clinic, as opposed to just treatment while they're in their eye test and their checkup appointment? Nobody else?
John, we are, but I can't seem to see. I have put my hand up, but you can't see me for some reason.
Okay, so that's Maria.
It's
No, don't worry. That's very kind of you to come in and say you are. So
yeah.
maybe some others are not are finding the same problem. But no, it's very interesting. You know, from the SightCare membership point of view, you know, the discussions we have around dry eye clinics, and when patients are aware that you are providing them not just this this sort of eye care as part of other care that you're giving, other treatment. It's a specialized clinic where they can come in at dedicated appointment times and get that specialist treatment, which a lot of practices who are doing this successfully are finding it, you know, it's a very, very good income generator for the business on top of your other services. So I'm very interested in that from a business point of view. So,
if I can add to that, John, beyond that, because they actually visit your practice a bit more, you really start to make those relationships. You know, you start to know them, and they start to know you in a very different way, and they start to trust you. And even if you, for example, don't have an IPL piece of kit, or you don't have every piece of kit, if you can explain it and understand it and recommend it, you're like a trusted voice. And they will always come back to you as well. So I think it's really important that even if you can't have everybody wants every piece of kit out there. That would be ideal, wouldn't it? That would be lovely. But even if we can understand it and explain it, that's going to be so much better than somebody else doing that for them, because they'll come back to you. They always do. So I know that when I was building our dry clinic, for the first time 12 years ago, didn't have that much money to do it. So I just had to know what was out there and kind of say, well, we'll go look for this, and I'll tell you why to look for this. This is what it's going to do, and this is how it's going to work. And then if you come back to me, I'll you know, we'll maintain your care. And I hardly lost anybody for that reason. And then we could invest more and more and more. So it's important to not just look for you know, I've got that and that's why I'm going to do that, but understand your plethora of what's in front of you and understand what's on your shelf and put yourself in that patient's shoes, and it really works.
And sorry, go ahead. Sorry, I thought somebody was coming in there. Would you be able to share with us this evening, Roz, what you would or what would you advise as being a fee, a patient fee? I assume you're doing this in terms of private eye care within your practice, and so just to give them, again, the people that haven't actually got that enhanced service set up, what sort of fee that you would charge from a...
Now, I get asked this question a huge amount, and it's not an easy question to answer because it does depend upon your practice and how you and how you've set it up. But I kind of look at it as clinical time, and because I'm a contact lens optician and I'm examining the front surface of the eye, and I don't do that much difference to when I'm actually examining the front surface of the eye. So it's the same job, right? I'm using the same set of skills. So I have to say, I think contact lens opticians are the best people placed for this. But aside from that, I tend to charge the same as I do for my contact lens checks. So my contact lens checks and my contact lens assessments is what I do as a dry assessment and my dry follow-ups, and then my treatments are on top of that. That's how I kind of tend to charge it.
Right. So in a sort of a menu approach, depending on what the patient you know wants to pay and needs. So and then
obviously you know, in the practice that I used to work in pre-COVID, we used to have a direct debit scheme where they would then have that my time included, and they'd get a discount on the treatments and the discount on the products and that kind of thing. And that really kind of helped with this online problems that we were having, or can, you know, that are apparent. I think shopping habits have changed now quite a bit, so that's something that's got to be thought about again. But yeah, generally it was always the same as a contact. So say if you charge £60 for your contact lens assessment, and that's your contact lens assessment, your initial and your, you know, follow up, that's what I charge. That's what I charge for a dry assessment.
And how,
there's always an initial and always a follow up.
Yes. And may I ask, how frequently are you advising your patients to be coming back for the, I presume part of that service, you're offering them as I say, a course of treatment over a period of time, so that they're not just coming in and having that single treatment. They're coming back again and again to have continuous treatment.
Yeah.
And to
so
be
if you kind of use your hygienist model, that kind of thing,
Yes.
usually you go back in for hygiene every 6 months. And if you think about, well, blepharitis and biofilm and gingivitis and plaque, well, it's biofilm. So it's the same kind of thing, right? And we do a little bit of maintenance at home by brushing our teeth, and we're doing a little bit of maintenance by maybe spraying some hypochlorous and doing some lid massage. I kind of explain it in the same way and get them to come back every 6 months. Now, some people will manage really well, and when they come back in 6 months and I look and I kind of think, actually, there's no need to do another treatment. You're doing really well, you know, fantastic. I'll see you again in 6 months' time. And then, or sometimes somebody may come in and they're managing really well, but something's changed in their life, their job, the environment they work in, that kind of thing. So suddenly the anterior eye is taking a lot more exposure of something else. Or if medically they've changed, then the aqueous they're going to be producing will have altered. So that's going to affect this whole disease dynamic as well. So I think that 6 monthly kind of like kind of checkup, a bit like contact lenses, is really useful. And you keep in touch with the patient and they keep in touch with you, and it's kind of forefront in their mind that way.
And you find it's a key differentiator for your practice amongst a very sort of busy, competitive environment with, you know, certainly the large, you know, multiples that are competing for your patient's time and business. So are you finding it's quite very successful?
I mean, yeah, I think the thing is, John, I mean, I've worked in multiples as well as working in independent practice. And I think, to be perfectly honest with you, I mean, I'm not just saying this, but I had a massive retention rate at the multiples as well. It was like 89%. And I had a really huge retention rate in when I worked in independent practice. And it comes down to the fact that it didn't matter if I didn't have the equipment, if I didn't matter if I didn't have the best lens or the best whatever, it's because you can explain it. And if you can do that, you really, really won't lose people because they trust you. Because people buy from people that they trust and they have a confidence in. And that's really what I'm talking about. So that's really what, if you want to use a word, that's what really sells. So that's what you have to impart, and that's what you have to kind of harness in the patient, that kind of trust, that feeling of trust. And as long as you're on solid ground, you've got it, you know. So and that's what I mean. I mean, as far as blepharitis goes, if you fit a contact lens and you look down the slit lamp, 9 times out of 10 you're going to see blepharitis. If you can manage that blepharitis, you won't need to keep refitting that patient's contact lens with different materials. Their contact lenses will just feel more comfortable. They're not going to get as many infections, and they're going to retain in their lens wear. It was the reason that they retained in lenses so much better.
Yes, so the patient education is fundamental to
exactly.
this area.
So I don't think you should, as a clinician, don't worry about your competitors. Just worry about what you're doing. Think about how you're communicating in your room, and think about the tools that are outside. And remember, this is disease management, so it's not about accuracy, it's about fluctuation and managing those ups and downs. And that's crucial. And I think if I'm going to be really candid, for optometrists, that's quite hard, because you practice for accuracy, right? So you measure, 0.25 cils that are 92 degrees and things like that. So your whole job is about complete accuracy, whereas my job is much more about managing the awkwardness in the situation. I fit very focused. I'm never going to get perfect vision. It's always about managing imperfection. So that's what you're doing when you're disease managing. You're trying to dumb it down, keep those spikes down, and you're managing imperfection. And as long as you have that in your head, that you're not going to fix something, you're going to manage it, you'll do okay, you'll do fantastically.
Lovely. Well, thank you for that. Do we have Barry, any more?
No more questions. No more acceptance for unmuting to ask questions personally. So I think we've answered everything.
Okay, well, that might be a good opportunity for me to say a very large thank you to Ros for giving us her time and her knowledge this evening. And I'd also like to thank the body doctor for working with us to make this this session available to members. We will be looking to do more with the body doctor going forward, so do keep an eye out for future webinars, and in particular CPD webinars. I know this is the last year of the CPD cycle, so it's a great opportunity to top up, and I'm sure that's what a lot of you are doing as well this evening. I'm sure Ros will be willing to take any questions through Barry or even through ourselves after the webinar if anything comes to mind. I'd like to say a big thank you to you all for joining us this evening. I know it's a very warm evening, lots of football on and lots of other tempting alternative activities. So we do appreciate you taking the time to join us. I'll hand back over to Barry now just to close the webinar and wish you all a very pleasant evening, and we look forward to seeing you again soon.
Thank you, John. Thank you, Ros. So just as a gentle reminder, when we all log out, you'll all have a short survey to complete, if you'd be kind enough to do that. And once that survey is completed and you log out, you'll receive a thank you email, and attached to that email will be the link to download your CPD certificate. So from myself, thank you so much for your time, and thank you for John and Ros again. And yes, any questions, please do email us or SightCare. Thanks very much, everyone. Have a great evening.
Thank you very much for your time. Take care. Bye-bye.
Thank you.
Bye-bye.
Bye. Take care. Bye-bye.